Good morning and good afternoon, depending on where you are on the face of the earth. Welcome to the Sickle Cell session at the 15th International Conference on Thalassemia and Other Hemoglobinopathies and the 17th Conference. Welcome. We are going to have 6 presentations, following which we'll have a questions and answer session. So I will advise that you keep your questions, post them, and we will address the questions during the Q&A. So this session is based on various topics on sickle cell disease. My name is Isaac Odame. I'm a professor of pediatrics and head of hematology at the University of Toronto. I'm based at the Hospital for Sick Children, where I'm the section head of hematology, and I'm the medical director of the Global Sickle Cell Disease Network. My talk will be beginning with sickle cell disease in childhood. I'm delighted to be part of this sickle cell session, and my topic is sickle cell disease in childhood. What do we mean by sickle cell disease? There are various types. Patients with sickle cell disease possess at least one sickle gene, and hemoglobin S makes at least 50% of the hemoglobin present. So there could be homozygous S, SS, also called sickle cell anemia, SC, S beta 0 thalassemia, also called sickle cell anemia, S beta plus thalassemia, SO Arab, SD Punjab, or S hereditary persistent of fetal hemoglobin, which is unique in that patients with this syndrome are asymptomatic. The single central event in sickle cell disease pathogenesis is hemoglobin S polymerization. And this is dependent on deoxygenation, acidosis, and a hemoglobin S concentration in the red cell. Following polymerization of hemoglobin S units, there are downstream events that lead to rigidity of the red cell, adhesion to the endothelium, and red cell breakdown, which is called hemolysis. With endothelial damage, there is also downstream activation of the inflammatory pathway, the coagulation pathway, all this combining together to cause vaso-occlusion. In the meantime, the hemolysis that results in anemia causes tissue hypoxia. The combination of tissue hypoxia and vaso-occlusion accounts for the vaso-occlusive pain, which is the hallmark of the disease, and even more than that, multi-organ damage, which leads to early death. Complications of sickle cell disease in children, therefore, could be seen as a combination of polymerization of deoxyhemoglobin and endothelial dysfunction in addition to hemolysis. And across the age spectrum, one can see that in early life, the main danger is bacteremia, particularly invasive pneumococcal disease. Pain is highly variable throughout early childhood and adolescence. Acute chest syndrome, which is a life-threatening complication. Acute splenic sequestration, which tends to occur in early life because by the age of 8 years, most patients with severe forms of sickle cell disease will have had functional asplenia. And the stroke, which is probably the most devastating complication of the disease. Chronic organ damage occurs later in adolescence and with time, and gives opportunities to pediatric clinicians to really embark on strategies to prevent or delay chronic organ damage. The impetus for newborn screening for sickle cell disease was given by this randomized control trial, the PROP study, the prophylaxis with oral penicillin study. In this study, 215 children aged 3 to 36 months were randomized between oral penicillin and placebo, and all received pneumococcal vaccine. And the outcome was to look at pneumococcal sepsis. There was early termination of the trial because whilst 13 cases of pneumococcal sepsis had resulted in the placebo group, only 2 in the group that received penicillin. This gave strong evidence that neonates should be screened for sickle cell disease and receive prophylactic penicillin by 4 months of age. Probably one of the strongest evidence that newborn screening with early intervention reduces mortality is in this Jamaican experience. I wanted to focus on the lower 3 curves, which represents a period in Jamaica from 1973 to 1981, when cord blood of newborns were tested for sickle cell disease. And at this time, there was no structured way of early interventions in sickle cell disease. This was a cohort study looking at the natural history. And you can see over time, this represents 1973 to 1975, 1975 to 1979, 1979 to 1981. So over time, there was some experience in managing these children, and there was improvement in survival. But this latest cohort is from 1995 to 2006. And that is when a structured program of early intervention with penicillin prophylaxis, educating parents, examining for splenic enlargement were instituted. And you can see if you compare that period with that period, there was a marked improvement in survival. Putting it in mortality rates at 2 years of age in a Jamaica sickle cell cohort, mortality rate was 0.14% compared to 0.1, a 10 times reduction in mortality. The same at 3 years, the same at 5 years of age. This provides strong evidence that newborn screening with early diagnosis, with early intervention with penicillin prophylaxis, vaccination, examination for splenic palpation, and comprehensive care with education of parents saves lives. And these survival curves really is an evidence of it. I wanted to focus on this one. This again showing the 73 Jamaican cohort compared to the cohort in 1979 to 81, showing the improvement, but with interventions that are early, including penicillin prophylaxis and comprehensive care. Mortality in the first 18 years of life is very low. This is not the same in low-income countries without newborn screening. It is estimated that 50 to 90% of children born with sickle cell disease in sub-Saharan Africa do not live to 5 years of age. In fact, the World Health Organization has estimated that about 9 to 16% of all under 5 mortality in certain parts of Africa are attributable to sickle cell disease. And why is that so? Basic facilities for sickle cell management are lacking. Newborn neonatal screening is not a common practice. And there's often late presentation with severe complications. And even when children die of this disease, it is not known that sickle cell disease was the cause. There's a lack of public awareness. However, over the last few years, there's been an epidemiologic shift, and this is as a result of decreasing under 5 mortality generally because of the measures taken in the Millennium Development Goals to reduce under 5 mortality. As a consequence, more children who have died in early life are surviving early childhood. And this paradoxically is leading to increased disease burden. The hallmark of this disease is pain events, and in children, a typical occurrence of dactylitis, which is often the first manifestation of the disease. The location of pain varies with age. It is usually in the hands and feet, and then it goes into the long arms and legs and lower back. Predisposing factors are well known, including infections, as well as exposure to cold or other extreme temperatures. Severity needs to be assessed properly, and home management should be through education and provision of potent analgesics to families to be able to manage at home. And where this fails, hospitalization is needed. Hydration should be done both oral and IV. Pain medication should be done with good escalation until the point where the child has significant pain relief as measured by pain scores. Non-medical measures like comforting, psychological therapy, distraction, and local therapies like heat compressors are very useful. Pain is a real disruption to children's lives, it disrupts school attendance. And when they are much older, it causes work absenteeism. And also vaso-occlusion may have a pain, may herald other complications of sickle cell disease. Acute splenic sequestration is associated with rapid enlargement of the spleen with the sequestration of blood and reduction in hemoglobin levels. Clinical manifestation includes weakness, pallor, tachycardia, with left abdominal pain with splenomegaly. And this can progress to shock and death in the severe cases. When poorly recognized and not recognized early enough, mortality rates can range from 12 to 20%. And when it occurs, recurrence rate can be as high as 50%. In the event that they recur or when they are very severe, splenectomy is an effective treatment. Therefore, clinicians to teach parents how to palpate the spleen so that there will be early recognition of this complication. And in settings where this has been practiced, acute splenic sequestration as a cause of death has drastically reduced. Acute chest syndrome is a very important complication of sickle cell disease, a major cause of morbidity and mortality. It's defined as a new lung infiltrate in the presence of fever and rapid breathing. Causes include fat embolism, infections, and in many cases, there's no direct trigger. But what is significant is that it may occur at the time when the patient has a vaso-occlusive pain event. As a result, treatment should include antibiotics, using broad-spectrum antibiotics, including ceftriaxone and macrolides. Also of note, complications of acute chest syndrome could occur as a complication of general anesthesia. These x-rays illustrate a case in point. This child on admission with vaso-occlusive pain episode had a chest x-ray that was really unremarkable. 6 hours following admission to the ward, this child became more tachypneic, showing real signs of respiratory distress. An x-ray at that point showed the real opacification on the left side, as you can see. And within 4 hours then, there was a spread of this opacification with evidence of fluid in the left hemithorax. The patient was taken to intensive care unit, was ventilated, and exchange blood transfusion was done. And 1 day after the exchange transfusion, we've supported with ventilation. You can see clearance of the lung and a marked improvement. Management of these patients should include good oxygenation, making sure that their hemoglobin is adequate, and in these settings, usually to be able to maintain high hemoglobin and reduce hemoglobin as concentration below 30%, exchange blood transfusion is needed. It is not enough just to prevent infection in sickle cell disease. One has to make every effort to prevent other manifestations of the disease, include pain, acute chest syndrome, hospitalization, and transfusion. For many years, hydroxyurea therapy has been proven to be an effective therapy in reducing pain, as in the multi-center study on hydroxyurea, reducing acute chest syndrome, reducing hospitalization, and reducing need for blood transfusion in a seminal study published in the New England Journal by Sharaj et al. In 1995. The baby hug study was a replication of that study in children 9 months to 3 years of age. And you can see that the same results as that were produced in the adult study were produced in the children as well, comparing hydroxyurea syrup and placebo syrup. The pain was reduced significantly. Acute chest syndrome reduced. Dactylitis, which occurs in children, was markedly reduced in those who got hydroxyurea compared to placebo, as hospitalization was reduced and transfusion requirements were reduced. Therefore, children benefit from hydroxyurea therapy just in the same way as adults, as shown in the MSH study. There have been concerns that hydroxyurea therapy might increase the risk of malaria infection in malaria endemic areas. This study, the whole No Harm trial, which was done in Uganda, was a study that regulators allowed a placebo study with hydroxyurea because it was not known what hydroxyurea would do in terms of malaria incidence in infants. So here, infants aged 1 year and onwards were randomized between hydroxyurea and placebo. And the primary outcome was the cumulative malaria incidence. And as you can see, there's virtually no difference in cumulative malaria incidence between placebo and hydroxyurea. But if you look at the curves expanded, you can see that in fact the hydroxyurea group probably has a trend towards a lower cumulative incidence of malaria. Secondary outcomes mirrored those of the baby hug study. Vaso-occlusive events were significantly reduced in the hydroxyurea group, hospitalization, transfusion requirements, and pneumonia and acute chest syndrome. Therefore, hydroxyurea therapy is safe in malaria endemic areas. And in fact, in subsequent trials, this was a single-arm trial, open label study of children with sickle cell disease in Angola, DRC, Kenya, and Uganda, where they were given hydroxyurea therapy and followed over the duration, starting with a dose of 20 milligrams per kilogram and escalating to maximum tolerable dose. In this study, you can see that all sickle cell-related events declined over time. And what was even more interesting was that malaria events reduced significantly. So rather than increase the risk of malaria, hydroxyurea therapy actually decreases malaria events. Vaso-occlusive pain events were reduced as would be expected. Transfusion therapy reduced, incidence of acute chest syndrome reduced over time, and there was a decrease in mortality. The National Heart and Lung and Blood Institute of the NIH constituted an expert panel to look at management of sickle cell disease based on the best evidence available. What I want to draw your attention to, this is concerning adults, but the one particular recommendation that was made based on strong and moderate recommendation and high and moderate quality of evidence is that infants after 9 months of age and adolescents with sickle cell anemia, that is sickle cell SS and S-beta-0 thalassemia, should be offered hydroxyurea regardless of clinical severity to reduce complications of sickle cell disease. Probably one of the most devastating complications of sickle cell disease is neurological complications. Without any preventive strategies or anything important, others show that overstroke occurs in about 1.0 in 100 patient years. Moya, which is a progressive stenosis of the distal internal carotid artery with an abnormal network of collaterals, occurs in 20% of children with strokes. Silent cerebral infarcts, in which there is infarction but no signs of overstroke, occurs in over 20% of children aged 6 to 19 years. And 37% of SS children show evidence of silent cerebral infarcts by the age of 14. And these are associated with significant cognitive impairments. What is even disturbing is that the incidence of silent cerebral infarcts, the prevalence, actually continues right from early childhood and continues to rise to adulthood. And this is really a significant burden and may account for even cognitive impairment in adult patients. There's an effective way to prevent stroke, and this has been one of the remarkable stories of sickle cell management in children. Adams and his group conducted the STOP trial, which looked at how to prevent stroke in children through chronic blood transfusion. Using transcranial Doppler technique, which measures the velocity of blood flow in the major vessels to the brain, they showed that for those at high risk of stroke, that is as interpreted by transcranial Doppler velocities above 200 centimeters per second, when randomized into two groups, the standard care which is no specific intervention, and a chronic transfusion to reduce hemoglobin S levels below 30%. They showed in patients aged 2 to 16 years, the period when these events tend to occur, that transfusion therapy was associated with marked reduction in number of strokes and in intracranial bleeding. And as you can see, 11 compared to 1 in the number of strokes and 10 compared to 1 in cerebral infarction. And you can see that transfusion therapy was significantly effective in reducing the incidence of stroke by over 90%. They then went on to answer the question, how long should transfusions be continued? In the study, in patients who were receiving chronic blood transfusion as stroke prevention because of high TCD velocities, one group discontinued the transfusion whilst the other group continued. In the group that halted blood transfusion, there were 2 incidents of stroke and 14 reverted to abnormal TCD velocities. Whereas in the transfusion group, no event was recorded. This suggested that there was continuing blood transfusion was the right way to pursue, and stopping transfusion was putting the children at risk. Therefore, most of these patients continued on blood transfusion and constituted a big burden in many treatment centers. The TCD switching to hydroxyurea trial called the TWICH trial examined whether in patients who were on chronic blood transfusions to prevent stroke and had normalized their TCD velocity, will switching to hydroxyurea maintain a normal TCD velocity. So in this study, the standard group were those who continued blood transfusion as per the STOP study, and the alternative arm are those who switch from blood transfusion therapy to hydroxyurea therapy. And as you can see, over the 24 months of the study, the TCD velocities were maintained equally in the 2 groups. This really brought a remarkable relief to many centers because one could now switch many of these patients on chronic blood transfusion to hydroxyurea therapy and successfully maintain TCD velocities. Of note, this trial enrolled patients with lower levels of CNS vasculopathy. It is doubtful whether those with severe vasculopathy and severe stenosis really warrant switching from blood transfusion to hydroxyurea. But it provides significant hope for low middle income countries where access to blood transfusion is a challenge, that hydroxyurea could be a good substitute for primary stroke prevention and even secondary stroke prevention, as revealed by this slide. That the hydroxyurea versus chronic transfusion for maintenance of TCD velocities, as per the TWICH trial, show that hydroxyurea can substitute for chronic blood transfusions to maintain TCD velocities and help prevent strokes. And in the case of preventing recurrence of stroke that has already occurred, this data shows the data on meta-analysis of several studies that were conducted on stroke prevention of stroke recurrence. Regular transfusions seem to be, at this point, the best way of preventing strokes, with 1.9 per 100 patient years incidence. No therapy that is therefore is not the way to go because the recurrence rate is as high as 30 per 100 patient years. Hydroxyurea performs creditably well, reducing stroke recurrence rates to 4 per 100 patient years. So in areas of the world where regular transfusions are not available, hydroxyurea therapy could be a substitute. But ultimately, no treatment is not an option. And even in regular blood transfusions, stroke recurrence can occur. And in these cases, curative therapies should be explored. So in summary, comprehensive care for sickle cell disease for children should involve newborn screening and early diagnosis, strategy to prevent infection, particularly invasive pneumococcal disease, penicillin prophylaxis, pneumococcal vaccination. All these gives the impetus for newborn screening. Malaria prevention strategies should be performed in malaria endemic areas, as malaria infections associated with severe anemia can be a cause of early mortality. Stroke prevention strategies are crucial. Management of acute complications should be done. Hydroxyurea therapy is an effective disease-modifying therapy and should be offered to patients with sickle cell anemia from 9 months of age. Blood transfusions are critical, particularly to prevent stroke and to prevent recurrence of stroke. Curative therapies are becoming increasingly available, and in some centers may be the only way to prevent recurrence of stroke in patients with severe vasculopathy. Management of chronic complications using multidisciplinary services, monitoring for end organ damage, which should be done early so that we will be able to prevent or delay end organ damage. But above all, patient and family education is critical, because when patients and families are well informed, early recognition of signs of sepsis or acute splenic sequestration or acute chest syndrome can be life-saving. The psychosocial burden of sickle cell disease of patients and families is huge, and psychosocial support should be an integral part of comprehensive care for sickle cell disease. To control this disease, prenatal diagnosis services and genetic counseling should be instituted in many jurisdictions in order to reduce the burden of sickle cell disease. Thank you very much for listening.
Thank you, Professor Odami, for this instructive and concise presentation. I'd like to introduce our next speaker, who is Dr. Lucia De Franceschi, and she's Associate Professor of Internal Medicine at the University of Verona, Italy. She's going to address a very important topic, sickle cell disease in adulthood. Welcome, Dr. De Franceschi.
Hello, my name is Lucia De Franceschi, working at the University of Verona, Italy, Europe. Today, my contribution will be a description of sickle cell and discussion of sickle cell disease in adults. Sickle cell disease is a monogenic disorder, but a multi-organ disease, as you may see summarized in these slides, is touching target organs such as the brain with cerebrovascular disease, lung with acute chest syndromes and pulmonary hypertension, but also kidney, liver, spleen, and of course, bone. These devastating and invalidating disorders resulting in impacting mortality and morbidity for sickle cell disease, but strategies that have been introduced, especially in pediatric population, allowed to improve sickle cell survival of sickle cell patient through pediatric age to adults, as you may see in these two cohorts of patients, one in North America and the other one in France, the Cretel cohort of patients with sickle cell disease, and is also highlighted by this survival curve, where you see definitely an improvement in the survival of patients in pediatric age here, with a shift towards right of the survival curves in the adults, with still a high mortality compared to healthy population measured by age and ethnicity. This means that we still have to work on both screening and intensive treatment for sickle cell related both acute and chronic complication in adult patients with sickle cell disease. This, in this study, has been considered the risk factors of early death in a cohort of adult patients with sickle cell disease, which are summarized in this table. And as you see, one of the parameters that definitely is affecting or is increasing the risk of death is highlighted by the red box, and is hemoglobin independently when you consider patient under hydroxyurea or off hydroxyurea. So this is in a way exploring the hemolytic profile of the patient. On the other side, we have total white blood count cells, we have kidney function through the glomerular filtration rate, and we have NT-proBNP, which is exploring the cardiovascular and pulmonary disease, as well as VCAM1, which is a soluble, in this case, is a soluble marker of inflammatory vasculopathy. So when we look to the same cohort of patients and to see which are the factors associated with patient survival and directly with the risk of death, you see that the pain frequency, hospitalization rate, and narcotic use, which are summarized in the graphs going from the up to the bottom part of the slides, you definitely see that patients with high pain frequency, high hospitalization, narcotic use have a survival reduced with sickle cell adults that do not present this profile. So when we go and look to which are the therapeutic intervention in adult patients with sickle cell disease, these are summarized in the present slides, and I'm mainly represented by 3 different actions. One is prevention, one is treatment, intensive treatment of acute events, and the other one is treatment of chronic complication. And of course, prevention means also vaccination programs, for example, for pneumococcus or influenza virus, and by now COVID-19 infection. And of course, intensive treatment and early treatment of infection like the urinary tract infection, infection on the teeth, which may accelerate the appearance of pain crisis. So what about acute events? As you know, acute events are characterized by pain. And so when we think to pain in patients with sickle cell disease, we have always to consider different factors that may involve and triggers acute vaso-occlusive crisis, even if in the large part of the cases is the main cause as difficult to be recognized. And in these slides, I wanted really to bring out which are the key events in taking care of patients with sickle cell disease, which is observe, listen, and learn from patients. And of course, pain should always be considered as our goal of to treat patient in order to make them to pass through acute pain, vaso-occlusive crisis with a good mood in order to have them to be able to take care of themselves and express themselves as a person in their life. When we consider a patient with sickle cell disease, the study have pointed out that the large part of patients with sickle cell disease are high utilizers of emergency department, even when you compare with patients with severe hemoglobinopathy, such as the thalassemia transfusion-dependent patient. And this is very important because this means that areas where there are sickle cell patients, the emergency department should have guidelines or recommendation in treatment of acute vaso-occlusive crisis, as well as areas where you can intensively treat patients with pain. And control pain in sickle cell disease means to know patient, to know the nature of sickle cell pain, to know pharmacology of analgesic pain or analgesic or painkiller drugs, and to define the moral identity, intent of the care provider, which is basically to support patient and to remove pain as soon as possible. And this, was a very strong driver in making a physician in different, physician in different area of the world, and I'm talking about Europe, to develop algorithm to manage acute pain crisis. And as you see in both, one on the left is from the United Kingdom and the right is from Italy, but there are common, strategy, which is the pain control within 30 minutes upon arrival at the emergency department, and of course the use of a strategy with the action, the use of a compound that can have an action on different mechanisms of pain characterizing sickle cell disease. And one of the best strategy concerning the pain control in sickle cell disease is the use of multimodal therapy, which is based on the co-administration of drugs with different pharmacological mechanisms of action, which are able to control different pain with different origin, and is the possibility to combine molecule with different profile either to maximize analgesia and to minimize the adverse side events. And this is very important in perspective concerning the use of opioid, taking into account that opioid are really, they generate problems in inducing postsynaptic morphological changes. So in perspective, their ability to be effective reduce with the time in patients with sickle cell disease. So examples of balance analgesia, these are the experience come directly from the physicians that are devoted to pain control, and they use, for example, of the infusion, the co-administration of tramadol plus ketorolac in adult, and as reported in this slide, the use of metoclopramide together to reduce the side effect related to tramadol, or in children, the use of tramadol plus paracetamol or ketorolac, and again, the use of the balance analgesia with multimodal approach. Very important in this context is also the possibility to use pain breaking drugs such as fentanyl, which is a very short-acting molecule, but is absolutely powerful in controlling acute pain. And this is very important when you consider the use, for example, of either buccal or nasal formulation for fentanyl as pain-breaking drug together with tramadol and ketorolac. And there are studies in both children and adults with this kind of therapeutic strategy, showing the importance of intensive treatment with different drugs, with different mechanisms in order to shortly reduce the period in which patients are exposed to severe pain. So how we treat a patient, which are the patients that is important to early identify. Since Europe is one of the area right now receiving the fluxes of refugees coming from an endemic area for sickle cell disease, one very important thing is to consider the possibility to identify refugees with sickle cell disease when they arrive to emergency department. And this again, for acute pain crisis, this again is highlighting the importance of having guidelines and recommendations for emergency department shared with either hematologist, internal medicine doctor, or pediatrician. And here is an example of a study we carried out in Italy due to the fact that we are one of the countries that are largely exposed to refugees fluxes. And you can see here, it was a study carried out throughout 2014 and 2017, and we identify a huge number of patients with sickle cell disease refugees arriving to the emergency department. And as you see here, the different countries where they were coming from, and we found CS beta patient, but also TDT patient. And of course, it's important to take care of identify this patient, take care of this patient, and give them the opportunity to have an access to hydroxyurea treatment as soon as possible, even if their final destination has not been defined yet. So going back to therapeutic intervention in adult, what about chronic complication? And there are a lot of them, as you may see here, summarized in the chart. But I would like to discuss of two of them very rapidly. One is pulmonary hypertension, and the risk factor in adult for developing of pulmonary hypertension are summarized in this slide. And again, we have anemia and hemolysis, abnormal kidney function, reduced lung capacity, and liver disease. An additional risk factor may be represented by sleep apnea, thromboembolic disease, and restrictive lung disease. When you think to early identification, early treatment, and intensive treatment too for pulmonary hypertension to reduce disease progression. The idea is to use, for example, echocardiography for TRV measurement and identification of diastolic dysfunction at least one or every 1 year, or every 2 years. Then the 6-minute walking test, the use of spirometry and pulmonary function test, hemoglobin, oxygen saturation, and LDH, and of course the use of NT-proBNP, considering the threshold of 160 picograms per milliliter as a risk for development of pulmonary hypertension. And since sleeping apnea may contribute to the development of pulmonary hypertension, to consider polysomnography if there are sleeping disorder described or recorded by a physician. What about kidney disease, which definitely is coming out as one of the major long-term complications related to sickle cell disease? When we look to advanced renal failure in patients with sickle cell disease, the distribution is definitely affected by the genotype. As you see here, we have 4.2% of SS patients developing advanced renal failure at the age of 23 years, and 2.4 patients with SC developing advanced renal failure at the age of 49 years. This is very important because it's definitely highlighting the fact that SC may be considered a sort of protective factor against terminal renal disease. It's also important to highlight that the detection of non-selective proteinuria is early presence in patients with sickle cell disease from pediatric period, so pediatric population to adult, and considering it more than 50% of sickle cell patients present non-selective proteinuria between the age of 36 and 40 years old. Protective phenotype, as I mentioned, protective factors, as I mentioned before, we may consider SC genotype, hemoglobin, fetal hemoglobin higher than 20%, and alpha thalassemia, which seems to delays the appearance of microalbuminuria. What about the screening program for early identification of kidney disease related to sickle cell? So abdominal ultrasonography again, the proteinuria by dipstick starting at the age of 10, and then the determination if dipstick is positive, at least two separate clinical evaluation, the determination of proteinuria of the 24 hours and the albumin creatinine ratio, which is very flexible and interesting parameter, which should be identified, should be carried out especially in adult patients with sickle cell disease, taking into account that the age of 20 is generally the turning point for the appearance of kidney disease in patients with sickle cell disease. So which may be considered a red flags in clinical comprehensive sickle cell center for adult patient with sickle cell disease, or albuminuria higher than 300 milligrams over the 24 hours, associated with increased creatinine over 0.7 milligram per deciliter in children and 1 milligram per deciliter in adults. So let's see the nephrologist and discuss with him or with her. And then, of course, albumin creatinine ratio with a threshold of 100 milligram per grams. And again, discussion with the nephrologist. So the back-to-back discussion of this patient with nephrologist, which is used, who needs to be used to discuss and who knows sickle cell disease, is really a key moment in clinical management of patients with sickle cell disease. Which are the risk factors for development of a severe sickle cell kidney disease associated with the albumin creatinine ratio? These are summarized in this slide, and as you see again, we have the age, the gender, And then we have anemia with the level of hemoglobin, bilirubin, so again, hemolysis. And of course, in this study, we evaluated one parameter, which is KM1, which is a parameter evaluating exploring blood, cortical, and medullary involvement, showing that this may be used also to, as a parameter to evaluate kidney involvement in adult patients with sickle cell disease. Which kind of therapy in these patients? So there are several studies, limited number of patients, generally are open label studies. These have been carried out with enalapril and captopril, which are AC inhibitors, blockers, and among these studies, the one with the angiotensin receptor blocker, losartan, a dose escalation from 50 to 100 milligrams per day seems to be the more interesting, showing a beneficial impact on ACR ratio with minor effects on or no effects on glomerular filtration, but at least show protective evidence on proteinuria. Something that has been very important to take into account is that we have to be cautious for possible hypotension and increase potassium levels in treating this patient, related to the fact that the large part of them develop a tubulopathy, which may affect potassium reuptake and related to the presence of free hemoglobin, which is blocking the aldosterone receptors. So in conclusion, the high biocomplexity of sickle cell disease requires reference centers with dedicated multidisciplinary medical teams, and a part of the mission of these medical teams is, of course, to update physicians and nurses in order to ensure a rapid identification, treatment, and follow-up of sickle cell related complication, and of course to maintain a back-to-back connection with patient association, advocacy at local level and national levels and international levels. And I thank you for your attention, and I'm here for any question.
Thank you very much for that well-structured presentation. Our next speaker is my co-chair, and that's Professor Adlet Inati, who is a professor of clinical medicine at the Lebanese American University School of Medicine, where she's a consultant hematologist in the clinical chronic care center. She's also head of pediatric hematology oncology and the director of the comprehensive sickle cell disease program at Nini Hospital, Tripoli, Beirut. Over to you, Professor Inati.
Good day to all. I'd like to thank the organizers and TIFF for including me in this important event. What I'd like to do today is to target effective management of pain in sickle cell disease. This is my disclaimer. Vaso-occlusive crisis, or VOC, or acute episodes of pain, as you all know, remain the most common debilitating complication of sickle cell disease. Despite our greater understanding of the etiology of sickle cell disease-related pain and new therapeutic modalities, pain management remains a common clinical challenge for healthcare providers for so many reasons. First, there's lack of strong evidence supporting clinical decision-making. There's significant management variability, and there's suboptimal awareness among HCPs about possible tools for managing pain. As you're all aware, the pathophysiology of vaso-occlusive crisis is multifactorial. It's not just straightforward polymerization of abnormal sickle hemoglobin. It's inflammation, adhesion, and all of this is important in highlighting the need for multimodal therapy in tackling this disease, and VOC in particular. Looking at the VOC and the cycle of vaso-occlusion, it starts with upregulation of adhesion molecules, and selectins are very important, particularly P-selectin. Inflammation cell activating, leading to multicellular adhesion of all blood elements and endothelial cells, going to vaso-occlusion and tissue and organ damage. And what you really see in our clinics, the VOC is just the visible tip of the iceberg. And down below is the most important. It is a silent vaso-occlusion, that multicellular adhesion, and that organ damage and endothelial activation that we would like to prevent or at least reduce. So VOCs are typically acute, severe, unpredictable, often requiring treatment with parenteral opioid. They involve any body organ. They associate with inflammation that worsens the recurrence, leading to so many complications and organ damage. Typical triggers are cold, stress, fatigue, illness, fever, pregnancy, hypoxia, dehydration, along with other things. And I'd like to highlight that today I will be talking about acute pain or VOC and not the chronic pain, which means pain that results in an unplanned visit to an acute care setting for treatment. We worry about VOCs because these episodes are associated with significant morbidity and mortality, high rate of healthcare utilization, hospitalization, and rehospitalization, recurrence, high economic burden, disrupted health-related quality of life, which is very important, impaired education and job attainment, and increased organ damage and mortality. And as you see on the right, in the graph on the right, you see that the survival of patients who've had more than one visit to the emergency department have generally a shorter survival compared to those with no visits. We would like to manage acute pain and sickle cell disease. Like in any chronic disease, we need to have set goals. And the two most important goals is first, ensure rapid, effective, and safe analgesic management and the resolution of VOC. But more important is to aim at prevention and or reduction of future VOCs to save the organs. And I would like now, when I talk about appropriate management, to really summarize the ASH 2020 guidelines and the National Heart, Lung, and Blood Institute Expert Panel Report 2014 guidelines, which I find very useful. So when you have somebody present to the emergency room, it's very important to rapidly triage, place, start pain assessment, and administer analgesia within 30 minutes in the emergency department. It's important to evaluate for complications on arrival, like acute chest syndrome. For those who have mild to moderate pain, paracetamol and NSAIDs are reasonable, but for those for severe pain, parenteral opioids are indicated. And if a patient is already on opioids, we need to tailor opioid dosing based on baseline opioid therapy and prior effective therapy. Important to reassess pain every 15 minutes to optimize pain control. And there are categories of patients who are hospitalized, who are refractory or not effective treated with opioids alone, or having an acute exacerbation. This is the time we can give ketamine. And also, there are patients who have localized pain who need regional anesthesia to really control this pain. Parenteral opioids need to be gradually titrated once VOC resolves. It's important to avoid metperidine and corticosteroids as well. And more recently, there's been emphasis, especially in the ASH 2020 guidelines, on non-pharmacological therapy as additive therapies to standard analgesia. And there's so many: massage, local heat, yoga, acupuncture, meditation, and others. We need to remember if somebody has a low oxygen saturation, oxygen has to be supplemented, maintenance hydration and not overhydration to minimize progress to acute chest syndrome and incentive spirometry. And anybody with VOC cannot be treated except in dedicated sickle cell disease facilities. And these could be hospital-based acute care, day hospitals, infusion centers, but the most important is to have expertise to evaluate, diagnose, and treat pain and other complications. And this is preferred over typical emergency department-based care. I'd like to emphasize here that for optimal pain management, no one-size-fits-all approach has to be used. Providing individualized patient-centered interdisciplinary pain approach is key and extremely important to always anticipate and treat complications, particularly acute chest syndrome and multi-organ failure. Are there any tips for emergency department health providers? It's important to believe patients, take their complaints seriously, and avoid considering opioid requests as a drug-seeking behavior. It's important to guide treatment by patient report on pain severity. This is very helpful. And it's key to work with a multidisciplinary sickle cell disease team to develop individualized care plans, especially for those with frequent ED use. And where possible, it's important to make these plans available in the electronic medical record. A multidisciplinary pain care team is key for managing people with sickle cell disease and people who come with VOC. And as much as family is extremely important, social support is important, but all these players are important, not only hematologists and primary care provider, but social worker, physical rehabilitation, psychologists, pain medication, nursing, and an integrative health approach. As much as treatment of VOC is important, but prevention is a key therapeutic goal that could reduce or prevent organ damage and mortality among patients with sickle cell disease. And we are lucky now to have so many effective therapy for VOC prevention. Hydroxyurea, which has been with us for years and years, transfusion in selected cases, and more recently, novel drug therapies like rizanezumab and L-glutamine, and in selected situations, hematopoietic stem cell transplant. In addition to those, and equally important, is patient, caregiver, and healthcare provider education on VOC, its triggers, and need to promptly report to ED. These play a key role in pain control. Hydroxyurea, a ribonucleotide reductase inhibitor, the first FDA-approved drug for treatment of sickle cell disease. Its efficacy and safety has been well documented across all age groups, including infants. It has been shown to result in so many improvements, hematologic and clinical, reduce VOCs. Unfortunately, it's often underprescribed with suboptimal dosing and inadequate exposure often. L-glutamine, which is an antioxidant, and DARI, it's an amino acid precursor to nicotinamide adenine dinucleotide NAD. So it reduces oxidative stress. It received FDA approval a few years ago to reduce VOC in adult and pediatric patients 5 years of age and older, based on a 48-week multi-center phase trial in 230 children. And its benefits have been demonstrated whether patients are on hydroxyurea or not. And as seen on the right, you see that the cumulative number of painful crises was 25% lower in those on L-glutamine versus those on placebo. And most recently, crizanlizumab, which is a P-selectin inhibitor, really targeting adhesion. It's a selective humanized monoclonal antibody that binds to P-selectin, but blocking all the adhesive, multi-adhesive process, received FDA approval to reduce VOC in both adult and pediatric patients 16 years of age and older, based on sustained trial, which was a 52-week phase 2 randomized multi-center placebo-controlled trial to look at the safety and efficacy of this drug. And as seen here, there was a significant 45% reduction in median annual rate of VOCs, leading to healthcare visits with high-dose crizanlizumab compared to placebo. And again, that was regardless of VOC baseline frequency, genotype, or hydroxyurea use. What about transfusion support? In the ASH 2020 guidelines, the indications for prevention, reduction of recurrent acute pain is not to use chronic monthly transfusion as first-line therapy, except when all pain control measures fail and shared decision-making can be applied. A trial of monthly transfusion can then be reasonable. Again, individualized approach is important. I'd like to highlight here and stress that chronic transfusion for pain management is a widespread practice that should not be used and associated with potential risk, harm, and morbidity. When to consider hematopoietic stem cell transplant for pain, prevention of pain? Again, the indication is not that common, but more and more as hematopoietic stem cell transplant conditioning and is getting better. This is indicated for those with frequent refractory pain earlier in life before onset of irreversible sickle cell disease-related damage. Matched donor transplant is recommended, and for those lacking a donor, a matched donor and alternate donor transplant only in the context of a clinical trial is suggested. So in summary, early diagnosis, treatment, and prevention of VOC are critical to the management of patients with sickle cell disease. However, as I showed, thanks to our increased understanding of sickle cell disease complex pathophysiology and vaso-occlusion, multiple agents have recently been developed for prevention and treatment of VOC. Education of healthcare providers, hematologists, about hydroxyurea optimization is extremely important, because hydroxyurea remains an excellent drug for prevention of VOC. Also, education about novel agents should lead to improved protocols for patients with sickle cell disease with expected reduction in VOC. But it's extremely important to believe patients and to provide individualized interdisciplinary pain management to individuals living with sickle cell disease with acute pain, because there's no one-size-fits-all approach, and it's hopeful that all these treatment approaches will be translated clinically into places where sickle cell disease is most prevalent. Thank you for your attention.
Thank you very much, Professor Inati, for that intriguing and precise presentation. Our next presentation will be on emergency care, and I have the pleasure to introduce Professor Paul Telfer, who is a professor of clinical hematology at Queen Mary University of London. He's also an honorary consultant hematologist at the Bath Health NHS Trust, London, UK. Professor Telfer, over to you.
So my talk is about emergency care for sickle cell. This is a talk which is largely based on experience in my service in the UK National Health System, but I think will have general applicability as well. Over the course of the next 15 minutes, I want to talk about pediatric emergencies. So that's emergencies in sickle cell which are we see in childhood, and what advice we give to parents about what to do if their child is unwell, if you think there's an urgent medical situation. I want to talk about acute chest syndrome, which is one of the common emergency situations in managing sickle cell, and which is often not managed very well, and also about how we transfuse, as transfusion is an important and sometimes life-saving intervention in sickle cell emergencies, and then some general recommendations. Now, this is a list of common and not so common emergency complications that we see in young children on the left and in older children, adolescents and adults on the right. Again, this will vary a little bit depending on the context where you're being managed in a developed country, in a developing country, and this is really based on experience in the UK in our setting. So some of these common complications in young children are really important to identify and to manage. And I'm going to talk about the ones highlighted in red, particularly invasive pneumococcal disease and acute splenic sequestration. And then, as I said, in the more elderly patients, I want to talk about acute chest syndrome. This is a bar chart which shows the frequency of some of the common complications, and this is based on data from our newborn cohort study in East London. And on this, you can see the range of complications represented as the number of events per 100 patient years of observation. And the higher the bar, the more common the complication. You can see that by far the commonest complication in the age ranges in this pediatric group up to the age of 16 is the blue bar, which is acute pain. I'm not going to talk too much about that, and that will be covered in some other talks in the meeting. The red bar next to that in all these age groups is the acute chest syndrome, which we're going to talk about. The others are much less common, but nevertheless important to recognize. The yellow bar there is splenic sequestration. You can see that's particularly a problem in the children aged under 2, and to some extent also in those up to the age of 5. Invasive pneumococcal disease is quite uncommon these days, but is important to recognize. So we're going to talk about invasive pneumococcal disease. This has been long recognized as an important cause of mortality and morbidity in young children with sickle cell. Children and adults are particularly susceptible to having a severe course with this infection, which is seen in the general population. It's a bacterium and which can be picked up in the community. How do we prevent it in children with sickle cell? Well, the first thing is education of the parent, and this is part of the early part of when we first see the parents of a newly diagnosed child, and we support and we educate them, is to make them aware of the risks associated with a febrile illness when the child gets rapidly unwell with a febrile illness, and they do need to be seen. Oral penicillin prophylaxis was introduced after a study done in the United States, a randomized controlled study, and this has become standard treatment at least until the age of 5, whereby this oral antibiotic is given twice a day to prevent or to help to prevent pneumococcal infection. We also have pneumococcal vaccination, and that includes the conjugate vaccine, Prevnar 13 in the UK and in many developing countries, which is part of routine childhood immunization. And this is a vital immunization to protect not only children with sickle cell, but all children against pneumococcal infection. And we also include specifically for children who are susceptible, including children with sickle cell, an additional vaccination called Pneumovax, which is a polysaccharide vaccine, and that has a wider coverage of different types of pneumococcus. And in our service, we give that at the age of 2, at the age of 5, and then every 5 years. Invasive pneumococcal disease can cause pneumonia, septicemia and meningitis, and there is quite a high mortality. And even in the current era where we diagnose children at birth, we provide parental education, support within a multidisciplinary clinic, and we have the regular oral penicillin prophylaxis together with the pneumococcal vaccination. This is still seen and is one of the most common or the most important causes of severe illness and mortality in young children. And this was shown in a study based on newborn screening in the UK, national study, where invasive pneumococcal disease is still probably the commonest cause of death in young children with sickle cell. So it's vital that the pneumococcal vaccination course is given, and that oral penicillin prophylaxis is given, and that parents are educated about the risks associated with a young child presenting with a high fever and other symptoms of infection, such as a high respiratory rate, difficulty breathing, a diminished level of consciousness, severe irritability. And these are all features of sepsis in a young child. I'm going to move on to the next complication, which is unique to sickle cell and is a particular problem in young children, certainly before the age of 2 and up to the age of 5. Splenic sequestration refers to the spleen, which is an organ on the left side in the abdomen, which gets blocked with sickled red blood cells. So the blood tends to pool in the spleen, and this results in an enlargement and a painful spleen, as I said, on the left side of the abdomen, and a drop in the hemoglobin level, which means anemia. And that anemia can happen very quickly and can be very, very severe. And this is another potential cause of mortality in young children. The presentation is with pallor, that means paleness, lethargy, irritability and abdominal pain. Sometimes splenic sequestration is also associated with other complications of sickle cell, such as dactylitis, infection, or pain elsewhere. And what's very important is to teach the parent of the young child, certainly with homozygous sickle cell, that's SS, to feel the tummy regularly, perhaps once a day, so that they're aware of what the child's tummy normally feels like and can identify the early signs that the spleen is enlarging. And an enlarged spleen will feel like a lump emerging from the upper left part of the abdomen below the ribs. So this is something that we teach the parents to do. If they feel that the child is unwell and the spleen is enlarging based on their palpation of the tummy, then they're asked to take the child to their care facility, which would normally be a hospital. And the doctors there should be familiar with this warning sign and institute the right investigations and management. The investigations include the full blood count, which will show that the hemoglobin level is really low, and that the reticulocyte count, which is a measure of the speed of breakdown and generation of new red cells, is very high. The treatment requires an urgent blood transfusion, and this should not be delayed. You don't need to do an exchange transfusion. It's just to replace the hemoglobin that's temporarily lost and to reverse the anemia. So this is something that we as clinicians need to be aware of and to be on our guard for and to treat urgently. In some children, this is maybe about 5 or 10%, these episodes recur, and in that case, because of the dangers associated, we would recommend a surgical procedure to remove the spleen so that in the future that's not going to cause problems. So those are two common complications which I just wanted to highlight. The advice that we give to a new parent of a baby or a young child with sickle cell, particularly the children with the severe genotype, that's homozygous sickle cell or HBSS, is how to recognize these potentially important and dangerous signs that the child is unwell and needs to be seen rapidly in hospital. So we need to educate the parent about sickle cell. There are books, there are other educational materials, and the discussion that one has in clinic with the parents is really important. It's good to be linked up with other parents, with the user group and the Sickle Cell Society in our country, which are also sources of information and support. What's very important is that the parent knows who to contact and where to go if the child is unwell. So there's a very clear line of referral and access to healthcare so that the urgent treatment that may be necessary to treat these complications can be provided as soon as possible. When to attend hospital, and this is particularly directed towards the parents. So if your child has a high fever, if your child looks very pale, is very lethargic, if there's chest pain, difficulty breathing, which may indicate an infection, a sickle crisis, or a chest crisis, which I'll come to, if the spleen is getting large, if there's a severe headache, or this condition called priapism, where the penis becomes erect and painful, not seen in young children, but in older boys and adults with sickle cell. These are some of the symptoms which indicate the need not to wait at home, but to go to hospital, to your care, to the hospital where you receive your care as soon as possible for assessment and management. Because if you wait too long, and if some of these complications are not treated quickly, then the outcome can be more severe. I'm now going to move on to the acute chest syndrome. This, as I've said, is the second commonest acute complication, but is probably the most dangerous and is associated with the highest mortality rates still. And again, there's a need to attend hospital and to get treatment quickly if there are the typical signs of acute chest syndrome. So what is the acute chest syndrome? It's an acute, that means a rapid onset pulmonary, i.e. lung illness. And it's characterized by chest pain, fever, cough, and dyspnea, that means shortness of breath. Some of these features may not always be present, but chest pain and difficulty breathing are very typical features. And an acute chest syndrome can develop during the course of an otherwise assumed to be uncomplicated pain crisis or crisis of sickle cell. So when somebody comes into hospital with a pain episode and then they don't get better, but the pain gets worse, and then they start to develop problems in the chest with chest pain, difficulty breathing, these are the telltale signs of a developing acute chest syndrome. And the way that we diagnose it is very simple, really. It's based on the presence of a new abnormality on the chest X-ray, which is obviously done in the hospital. And I'll show you some examples of that. So for the doctors here, the diagnosis and the assessment of acute chest syndrome, again, it follows the principles of general acute emergency medicine. So first of all, the symptoms of an increasing pain, increasing chest pain, difficulty breathing, and cough, often with cough. Now, we use the National Early Warning System, or the Paediatric Early Warning System, in the UK National Health Service, and I'm sure that similar systems exist in other countries. And this is just a way of gauging the severity of the situation by measuring vital signs. And what you're looking for is an increased respiratory rate, an increasing pulse rate, decrease in oxygen saturations, and often a fever. And of course, these vital signs will often be abnormal in a whole range of different medical conditions. But if you see these in a child or an adult with sickle cell, these are very strong signs that there's an acute chest syndrome developing and that you need to act. But the way that you act is not with the sort of general medical hat on, if you like, of diuretics or antibiotics. You need to get on with specific treatment to reverse the sickling process. On examination, there are often new signs on examining the chest. So there may be, when you listen to the chest, there'll be crepitations, decreased breath sounds, and quite typically signs of consolidation, bronchial breathing, and increased vocal resonance at the lung bases. Here are two chest x-rays. The one on the left is a young child showing what appears to be a lobar pneumonia on the right side there, in the right lower lobe, and on the right side, that chest X-ray is of an adult showing bilateral chest changes, pulmonary changes at the lung bases. Both of these are diagnostic of an acute chest syndrome. It's possible that the 4-year-old on the left there actually has a pneumonia, but we would still call that an acute chest syndrome. And often in the young child, there is this more sort of pneumonic type presentation, sometimes without too much pain. And this child would require antibiotics, but would also require painkillers if needed, plus consideration of the need for transfusion. The adult on the right is very typical of a severe acute chest syndrome, which requires early intervention to prevent rapid deterioration. So how do you manage this? So analgesia is important because if it's too painful to take a deep breath, then that will diminish air movement and oxygen delivery in the lungs. So analgesia, which is really needs to be opioid analgesia, needs to be carefully managed. We often use fentanyl given by intravenous patient-controlled analgesia because fentanyl can be titrated quite precisely and can be used to get on top of the pain without causing respiratory suppression, which may happen if you overdo long-acting opioids. Obviously, you need inhaled oxygen to maintain good oxygen saturations. If the patient will tolerate it, physiotherapy and incentive spirometry. Very careful fluid balance to avoid fluid overload. This isn't a problem of where hyperhydration is needed. We would normally give antibiotics, broad spectrum antibiotics, as mentioned there, and bronchodilators. And severe cases, when they need enhanced respiratory support with high flow oxygen, CPAP, positive pressure, airway pressure, and even mechanical ventilation. I've mentioned the analgesia, and we would involve the pain experts in managing these patients. Transfusion is really a very important consideration here and is often very important to reverse the process and can be life-saving. For a mild acute chest syndrome, where there isn't evidence of rapid progression, but just some mild changes on the chest X-ray, we may not transfuse, but just institute the management that I've described in the previous slide. For a moderately severe acute chest syndrome, where there is a significant respiratory problem, but is perhaps not rapidly progressive, and the hemoglobin level allows this, in other words, the hemoglobin level is below 90 grams per litre, we might consider a simple transfusion. So that would be a simple top-up transfusion of somewhere between 10 and 20 mils per kilogram. But we have to be very careful not to over-transfuse and increase the hematocrit too much, because then you may run into hyperviscosity problems. So for those with a more severe acute chest syndrome, rapidly progressive, then an exchange transfusion is needed. And the function of the exchange transfusion is to bring the sickle hemoglobin percentage down low, certainly below 30%, and at the same time to maintain the hemoglobin level at a level of somewhere between 9 and 11 grams per deciliter to prevent a severe anemia and to maximize oxygen transfer. I'll come back to the issue of transfusion a little bit later in the talk. In fact, right here. So if you're doing an exchange transfusion, this can be done in two different ways. Either manual, which is quite labor intensive, and surprisingly, even though this is a procedure which has been done for so many years, there's a great deal of variation in how it's done, and with a variation in the results obtained as well. And these days, what's rather better and generally quicker is if you have the facilities to do an automated red cell exchange transfusion using a device like this Spectra Optia. And with this methodology, you can bring the sickle hemoglobin level down below 30% with one procedure lasting about 3 or 4 hours. You need very good venous access using peripheral, or if that's not possible, central cannulation. And you need experienced practitioners who know how to use this apparatus. So in the UK setting, we have a team that we can call out 24 hours a day for those in our specialist centre who may be referred in from other centres who need urgent exchange transfusion. And they would use this automated exchange procedure. And the results are often quite dramatic in terms of the reversal of the acute chest syndrome and the return to normal vital parameters fairly rapidly. If it's left too late, though, then even exchange transfusion may be too late. For the manual exchange transfusion, it's quite important that you have an understood protocol for doing this, which involves taking blood out and giving back blood, and take those procedures done manually. This is a scheme that can be used. This is what we use if we do need to do a manual exchange, and I'll show you a reference to where you can find that scheme. There is also a YouTube animation that's recently been produced. I put the reference on the screen there, which might be helpful. This has been produced by our National Blood Service and might be helpful for those who don't have a protocol within their service for doing a manual exchange transfusion. So in conclusion, and here are some general recommendations for managing acute complications of sickle cell. There are a few misconceptions that are quite often perpetrated by those who are not specialized in sickle cell management. There is a feeling that children and adults with sickle cell need to be hyperhydrated, and this in some way will reverse the sickling process. This is generally not the case. Obviously, hydration is needed, and certainly if the patient's dehydrated, that can be helpful. But just general protocolized overhydration is not a good thing to do, and certainly in acute chest syndrome can actually be damaging. There is also a tendency to transfuse for any acute complication, and this is not necessary and can also provoke transfusion-related problems like alloimmunization and other transfusion reactions. So for a simple acute pain crisis, for instance, even if the hemoglobin level is slightly lower than the steady state, I would not advise routine blood transfusion. There are indications, as I've described in this talk, where transfusion is needed, but not as a sort of blanket for any acute complication. Another thing that we've learned over time is that surgical intervention can sometimes be needed, but sometimes surgical intervention is unnecessary and potentially harmful. If you show an orthopedic surgeon, for instance, a child or an adult with a swollen limb, that will usually provoke them to want to do a surgical procedure to drain a supposed osteomyelitis. In general, particularly in young children, a swollen joint or a swollen limb is not a bacterial infection. It's simply a vaso-occlusive episode, quite a typical presentation of a vaso-occlusive episode. So best not to involve surgeons because they will do what they would do in a non-sickle situation. However, having said that, we do occasionally see osteomyelitis, usually due to salmonella infection, and here surgical drainage and for diagnostic purposes also might be needed. So clinical judgment is clearly needed. Similarly, occasionally children present with a painful swollen abdomen with reduced bowel sounds. And to a surgeon, that might look like an acute abdomen, like acute appendicitis. In our experience, this is more likely to be a sickle crisis, which we call a girdle crisis, where you get a swollen abdomen with distended bowel loops, and it's often associated with sickle pain elsewhere, and no surgical intervention is needed. You may well need to do an exchange transfusion, but a laparotomy is actually going to make things a lot worse. So here again, clinical judgment is needed, and knowledge of the spectrum of presentations of acute sickling rather than other surgical problems. So my second slide of conclusions and recommendations, and these are more general: regular and systematic education of parents, patients, and also the non-specialized and specialized staff working in your unit is really important, so that there's an increased understanding, because sickle cell is a specialist area, and the kind of complications that we see are rather unique, or many of them are rather unique to that situation. And if you've not seen sickle cell before, then you may make a wrong diagnosis. I think that clear and easily available protocols for diagnosis and management of sickle complications are really needed. And it's important that you develop those and have those available within your unit, speaking to the specialist doctors here. Similarly, it's very important to be very clear about the pathways of care throughout your hospital and between hospitals if you are acting as a referral center for other hospitals. These have to be very clear so that there's no delay in getting a patient into your unit for urgent treatment when needed. And clear means of communication with the expert team and for transfer of patients to specialized centers, for example, for automated exchange transfusion. Finally, I think the other principle, which I haven't talked about in this talk, but I'm sure will be covered by others, is the need to prevent these complications. We've talked about how we might prevent pneumococcal infection with antibiotics and with pneumococcal vaccination, but preventing of acute sickling complications does involve disease-modifying treatment. The one oral treatment we have at the moment is hydroxyurea, and hydroxyurea should be offered certainly to those who have a past history of acute sickle complications. If hydroxyurea is not tolerated or for other reasons it's not possible to use hydroxyurea, then you may even need to consider regular transfusion. And within our unit, we have a number of patients who have regular transfusion as a treatment to prevent acute sickling complications, not just stroke and neurological complications, but acute vaso-occlusive episodes as well. So I haven't covered every single sickle complication, as I only have 15 minutes, but I hope I've given a background and about the general principles, and I've highlighted some of the important complications that we see commonly in the hospital. And I'll stop there. Thank you very much.
Thank you, Professor Telfer, for this highly educational session. Now it's my distinct pleasure to introduce a dear colleague, Dr. Miguel Aboud. Dr. Aboud is Professor of Pediatrics and Hematology Oncology and Head of Sickle Cell Disease Program and Chairman of the Department of Pediatrics and Adolescent Medicine at the American University of Beirut Medical Center, Beirut, Lebanon. Welcome, Dr. Aboud.
Good day, and I would like first of all to thank the Thalassemia International Federation and the organizers for inviting me to talk in this very important session on sickle cell disease. I will be trying to talk today about the need for multidisciplinary care in sickle cell disease. I'm Miguel Aboud, and the Professor and Chairman of Pediatrics at the American University of Beirut. Sickle cell disease is a disease which was first characterized molecularly over 60 years ago. And it's due to a single base substitution leading to a single amino acid substitution of valine for glutamic acid in the beta chain of hemoglobin. As you all know, patients could have sickle cell anemia where they're heterozygous or homozygous for this mutation, or they could be heterozygous with forms of beta thalassemia and other hemoglobins such as hemoglobin C. This simple mutation leads to a multifaceted pathophysiology in this disease that has some main elements, including chronic inflammation, heterocellular aggregates leading to vaso-occlusion, and therefore ischemia and reperfusion injury, and also it is a hemolytic anemia and characterized by hemolysis. The vaso-occlusion and intravascular hemolysis that result from polymerization of hemoglobin S are responsible for infarction, inflammation, hypercoagulability, increased free hemoglobin, decreased nitric oxide, and these lead to acute and chronic complications involving multi-organ systems. Hence, the complex pathophysiology, and one can see from here that a multidisciplinary approach has to be taken into consideration to manage complications as varied as retinopathy, leg ulcers, kidney disease, lung problems, and I will be using lung problems and kidney disease and vaso-occlusion as examples of the need for multidisciplinary care. Now, it is well known that mortality in sickle cell disease has been decreasing and survival improving over time, despite the fact that still adults do not live as long as people who do not have sickle cell disease. But it's to be noted that the advances since 1960 till the 2000s have been made without there being a cure for this disease. And this is in very large part due to comprehensive multidisciplinary care, primarily in the pediatric age group, that has led in developed countries and in some countries such as Jamaica to over 98% survival from childhood to adolescence. In adults, it's a different matter. And I will talk today about the multidisciplinary care in pain, pulmonary complications, renal dysfunction, more importantly, the psychological implications of this, the need for multidisciplinary care even in therapy, and I will talk about transition. Now, if we look at acute events that lead to the admission of patients with sickle cell disease to the emergency room, pain crisis and acute chest syndrome are high on the list. And pain crises are really the hallmark of this disease. Dr. Ballas, a graduate of the American University of Beirut many years ago, described the 4 phases of these painful crises. And as you can see here, these are associated with activation of coagulation, adhesion molecules, but more importantly, look at what we have: numbness and paresthesias, problems with ED personnel, joint effusions, upon admissions, problems with hospital personnel. All of these have been well documented, and all of these would require that the patient with a pain crisis receive a multi-faceted approach. And this is even more so for patients who suffer from continuous chronic pain and experience breakthrough painful episodes. Now, what are some of these problems, and why do emergency medicine providers have to be a part of the multidisciplinary team taking care of these patients? We have, and others have noted, that sickle cell disease patients presenting to the ED experience longer wait times than other patients groups. For example, if somebody comes in with a renal colic, this is so even after accounting for the assigned triage level, people can be triaged to urgently needed care, but they still have to wait. Now, the management of acute VOCs related to sickle cell disease by emergency providers is more effective where guidelines are available. Another area where hematologists, pain specialists, nurses, and ED, both from the sickle cell clinic and the ED, have to get together to develop guidelines that are applicable in a certain institution. We know that there are universal guidelines for pain management. These are clear: hydration, not overhydration, opioids, etc. But these need to really be suitable for a particular emergency room. It will be very nice to have the guidelines for IV doses of morphine, but what about a hospital where morphine is not available? It's rare in most countries, but it happens in some, and these need to be really evaluated. Also, in a multidisciplinary manner, barriers to effective pain management need to be looked at. These include socio-cultural factors affecting pain assessment and concerns usually misplaced that the hospital staff may have regarding addiction and pseudo-addiction. Now, having said that, what about the impact of acute pain on patients with sickle cell? We already saw it might impact their relationship with healthcare providers, but let's look at this situation. Now, I was part of the steering committee of the SWAY study, and this is an international survey of sickle cell disease experiences. And we defined pain crisis as severe pain crisis, including those managed at home. And in our survey of over 2,000 patients, 91% reported experiencing at least one pain crisis in the previous year, and 12% reported experiencing more than 11 pain crises in the previous year, and the mean number of pain crises was around 5 in the previous year. So a very, very frequent event. And vaso-occlusive crisis, pain crisis, cause up to 95% of hospital admission in the United States. And although not ideal, emergency rooms are the default for patients who experience pain crisis, as they are open 24 hours, have expert caregivers. But as we mentioned, the mean pain time from triage to pain medication administration is about an hour, and the healthcare costs associated with this are high. What do the patients say? And here it's very important. Patients say that this is unbearable. The pain is like being hit by a truck. It's stabbing, excruciating, and really most of the time very severe pain. Also, we have to recognize that sickle cell disease is a multi-system disorder, and that many complications are associated with pain. And moreover, all of these complications can happen in the disease, and they are really important to be managed by experts. So just looking at this diagram, one can see that we need to have skin wound experts for leg ulcers. We need orthopedists for vascular necrosis. We need neurologists, ophthalmologists, pulmonologists, nephrologists, and so on. The systemic complications of pain of the disease include chronic anemia, and pain include chronic pain, neuropathic pain, central desensitization, and the other risk of infection due to perhaps early splenic infarction is also there. Now, the care model for vaso-occlusive crisis that we have definitely can be improved with a multidisciplinary approach. This entails specialized care centers, less busy than the ER, more sickle cell disease specialists, better pain management, and reduced hospital admissions have been associated with patients who are treated in sickle cell care centers. We are going to need community outreach to really educate these patients, and this has been shown to reduce hospitalizations and reduce hospital stays. Now, what about primary care? AR and the hospital admissions can be decreased if there is close collaboration between sickle cell disease specialists and general practitioners. And here at AUB, we practice that. We have a network of pediatricians who see our patients, and they are in constant contact with our center. Now, importantly also, hospital pain management that's effective can improve patient outcomes, and planned page management can reduce admissions. And this entails there being in the hospital a pain management team that is specialized, that understands sickle cell disease, and sees the patients in a timely manner. Also, this whole group can develop guidelines for use in the ED or as outpatient for the management of pain crisis. So pain crisis, a critical part of this disease associated with other problems, but can be very effectively managed with a multidisciplinary approach. Now, what else have we learned from SWAY, the Sickle Cell World Assessment Survey? We have learned that patients experience a significant number of symptoms. These are the patients who were surveyed, and they had fatigue, bone aches, headaches, joint stiffness, depression, breathing issues, anxiety, insomnia, complaining of yellow eyes, poor appetite, difficulty concentrating, difficulty in gaining weight, vision issues, constipation, itching, memory issues. Very few patients, 2%, said they had no issues at all. Again, here are the percentage of patients who expressed that these problems were severe, severity between 5 and 7, 7 being the worst. So you can see many patients experienced significant symptoms, pain not being the only one, and many of these were severe, including fatigue, bone aches, headaches, and depression. Again, comes up very importantly, difficulty concentrating. Hence, and in every patient panel that I have conducted recently, and we have conducted one here and one for the Sickle Cell Disease Association, one need that always comes up from the patients is the need for psychological support. Now, before SWAY in 2015, we carried out in Lebanon a study to look at the daily lived experience of adolescents with sickle cell disease in Lebanon. We chose 12 adolescents screened clinically. They were Lebanese and Palestinian. Most had low socioeconomic status. 11 were SS. And we conducted a survey. This was published, and pain was a defining characteristic of the disease, limiting their abilities and shaping how others view them and how they view themselves, consistent. They were concerned about the burden of the disease in the family. We found that caregivers play a therapeutic role. Mothers were usually the primary caregivers, and academic performance required heavy concentration, and physical attendance was usually difficult, and religion was a coping mechanism. Again, you see reflecting in an adolescent population that's younger than the sway population the same issues. Pain is a defining characteristics, but there are other issues that came up. And for these patients, pain was bad, but was not the worst part of the sickness, rather a normal experience. And they desired normalcy, and they really wanted to be viewed as normal. They had a sense of guilt and sympathy towards their families because they felt they were a burden of the family and responsible for physical and emotional stress. They had a tendency to downplay their symptoms. They were concerned about parental overprotection, and the siblings shared a lot of empathy with the siblings with sickle cell disease and understanding. But you can see here the enormous psychological burden seen by these patients. Again, my friend Wally Smith a while back conducted the PISCES study, which was the study looking at the epidemic of pain in sickle cell disease, the epidemiology. And they found out that patients who had a high somatic burden of symptoms, and here they looked at the at a questionnaire that had 15 symptoms, many of which are included in this SWAY survey. They looked really at 11 that had less direct relation to sickle cell disease. And they found that the patients with high symptom burden had a higher risk for depression and for anxiety. Patients, so these symptoms that we saw can be associated with significant anxiety and depression, therefore a major need for psychological support in this patient group. Now, what I'm going to just illustrate a couple of other things. Pulmonary complications are the leading cause of death. The two most common acute events are vaso-occlusive crisis and acute chest syndrome. And I want to just mention that patients with asthma have a higher mortality than other patients with sickle cell disease. Now, acute chest syndrome, this group should be familiar, a new infiltrate, usually involving a complete lung segment with chest pain, fever, tachypnea, and hypoxia. And it can complicate up to 30% of admissions for vaso-occlusive crisis. Also, it's the most common post-operative complication in sickle cell patients. So two areas here where multidisciplinary care might have an impact: decreasing acute chest syndrome during hospital admissions and in the post-operative setting. Again, the causes are multifactorial. Infections can be a cause, marrow emboli, and atelectasis due to pain management and fluid overload. So you can see here how adequate pain management with the team is important. And again, infections can be a cause, so we need to really have infectious disease on board. The management, hydration, antibiotics, bronchodilators, we always have our pulmonologist on board with us, as well as in patients who are not doing well, our pediatric intensive care specialist. Now, the management, transfusions, these need to be phenotypically matched, so expert blood bank support, pain management with the team, and oxygen. Now, these can be prevented by hydroxyurea, chronic transfusions. Of course, patients undergoing stem cell transplant do not have acute chest syndrome. But more importantly, remember what I said. What about a multidisciplinary, multimodal pain intervention with caregiver education? This was shown to decrease acute chest syndrome rates in patients admitted for pain crisis by half. And this was a study published. It has been reproduced since, And it led me to call acute chest syndrome an iatrogenic condition. And this was done in a large tertiary care centers. The investigators developed standardized orders, and they provided staff caregiver education. And they looked at 300 admissions, almost evenly split between before and after developing these measures. And they showed that the acute chest syndrome rate in patients admitted originally for pain crisis declined from 25% to 12%, and the time to develop acute chest syndrome also almost tripled from 0.8 to 1.7 days. So again, if there is a multimodal approach with a pain team, nursing education, incentive spirometry, and so on, and decreasing fluid overload, medical staff education, you can decrease a significant complication like acute chest syndrome. I not want to talk here about the kidney disease in sickle cell patients, which is significant and can end up in end-stage renal failure, but also in patients with acute chest syndrome, many of them ended up with acute kidney injury. And the longer they stay in the hospital, the higher the rate of acute kidney injury. So you can see here the number of patients who developed acute kidney injury. Patients with yes, they developed it in a median of 15 days, and they had a intubation rates that were higher. They also had longer hospital stays. Okay, and so you can see here that in these settings, we are going to need all the expert help we can get to manage these patients in a multidisciplinary manner. Now, having said this, the management of sickle cell disease should always be multidisciplinary. Preventive measures, neonatal screening, starting with the newborn screening team, implementation of penicillin prophylaxis and immunizations, monitoring of TCD, transcranial Doppler for stroke risk, screening for pulmonary hypertension, assessment for other organ dysfunction, ophthalmic evaluation is critically important, supplementation with nutritional goals, and family and patient education are important. In addition, as new therapeutic options become available, the expert team has to be assembled to be able to provide this. I'm going to talk a little bit about transfusions, which are very effective in sickle cell disease. They can be indicated in the setting of acute chest syndrome, stroke, severe anemia, aplastic crisis, sequestration, and preoperatively. But they are associated with problems: alloimmunization, delayed hemolytic transfusion reaction, hyperviscosity, and iron overload. Now, for alloimmunization, we can prevent this by phenotyping the patients and providing phenotypically matched blood. This requires an expert blood transfusion service. And these are the recommended transfusion guidelines that were published in Blood about 3 years ago. And you can see just how involved it is to give transfusions to these patients if they are to be done properly. You can see that patients in a chronic transfusion program with no history of delayed reactions, if they are at low risk for delayed hemolytic reactions, you match for RH and K. If they have at least one antibody, they need to be matched. Further, here at the American University, we matched for all 4 major antigens. And if patients are receiving episodic transfusions, also they need to be evaluated very thoroughly, and we need to prevent delayed hemolytic transfusion reactions in a very timely manner. And this will involve extended cross-matching and perhaps the use of rituximab or IVIG. This is I don't mean to elaborate on the exact details of the transfusion management, but just to see how involved it is and how important it is to have a good blood bank and transfusion service. Now, one important area which is neglected and where multidisciplinary care is essential is transition. For adolescents and young adults with sickle cell disease, the stakes are high. There is a documented increase in healthcare utilization, morbidities, and mortalities after 18 years of age in the US. And this is the number of patients. You can see here that even though the number of patients with higher ages is going down, the ED visits go up. Therefore, all the problems I had shown before increase. And again, the percent of admissions goes up as the ages go up. And you can see here that there are more readmissions as the age goes up. So there is an increased rate of both visits and readmission visits, therefore amplifying the problems we talk about. What are the perspectives? We saw what the patients say about pain. I feel in the once they go through transition and they are in the adult service, they feel scared, they feel abandoned. I just hope she's responsible enough to do it when she gets out there. Everyone is talking to her to prepare her. It's just when she actually does it. These are parents. Doctors kind of know me by face, and I feel like he kind of just looked at me like, you are back again. What do you need this time? I don't. And the patient says, I don't appreciate that. I'm not here doctor shopping or anything. So significant issues, and there are a lot of fears with transition, leaving trusted provider or providers, mistrust, problems with adult access to care, problems navigating the adult healthcare system, lack of support, and feeling unprepared. And there are many barriers to this: poor self-management skills, low patient engagement, lack of support, the emergence of end organ damage, accumulation of comorbidities, lack of trained adult providers, the cost of care, and the poor coordination of care in most adult care settings. And so there are socio-behavioral health system factors and faster disease progression. And all these lead to a deterioration of patients' health during transition with increased morbidity and mortality. So an area that really requires a multidisciplinary care and approach. Now, how can this be done? There is a socio-ecological model of adolescents and young adults' readiness for transition. These take into account socio-demographic, cultural factors, medical status and risk, neurocognition, and societal stigma and lack of awareness. And also, this model looks at modifiable factors, components of patients, parents, and providers that can be targeted to help improve. These include knowledge, skills at self-efficacy, pain management, and healthcare navigation, the beliefs and expectations of the parents and of the patients, and the developmental maturity of the patients. Also, it's important to know what their goals are, and what the psychosocial status and emotional is. And this needs a team, a whole team, to take charge of this and take care of these patients. And the predictors for successful transition are self-efficacy, readiness, adherence to a plan, model programs, and patient-centered medical home. So there needs to be a medical home in a community. There needs to be provided leadership. There needs to be a care coordination team, continuity of care, patient engagement and self-management, and teams that are associated with access to care and really foster this transition process. Now, here is my biased vision. We need hematologists, adult and pediatrics, general practitioners and ED specialists. We need psychologists, social workers, nursing, and genetic counselors. And of course, we need to have the support. And I could go on and on here, pulmonologists, nephrologists, ophthalmologists, but very critically, a blood bank specialist. Now, to summarize the conclusion, that sickle cell disease is associated with many potential complications, including pain and acute chest syndrome, leg ulceration, and so on. Preventive measures, early detection, and ongoing patient monitoring are necessary steps to minimize and manage complications. This can really only be done in a multidisciplinary setting. Other patient-centric interventions may also be required to achieve relief of complications, and these also require multidisciplinary consultation and follow-up. Attention needs to be focused on quality of life and psychological well-being of patients, and transition is critical, it's important, and also requires a multidisciplinary effort. With this, I thank you, and I hope to take questions and discuss it with you.
Thank you very much, Professor Aboud, for deep insights into what comprehensive care for sickle cell disease entails. Our last but not the least presenter in this session is Khaled Musalam, who is the Group Chief Research Officer, VPS Healthcare, Abu Dhabi, UAE. Khaled is President of the International Network of Hematology based at London, UK. He's going to talk about comparative analysis of guidelines and standards for clinical management of sickle cell disease. Over to you, Khaled.
Hello, good morning and good afternoon, everyone. Thanks for Tiff for inviting me to present in this meeting. I hope you enjoyed the program so far. What I'll be presenting is a comparative analysis of guidelines and standards for clinical management of sickle cell disease. I must admit it was an exciting and interesting task for me to actually look into the available guidelines and try to do as much comparison as I can with them. And I'll walk you through the findings of this exercise that I've done specifically for this presentation. These are my disclosures. So just to give you a sense of the search methodology that I've gone into to be able to identify the guidelines to begin with, because we didn't want to do this exercise or this analysis on a predetermined guidelines. So I did what I would like to call a semi-systematic approach to get the main guidelines that are available in the literature at least. And I called it semi-systematic because obviously it was done for the purpose of this presentation to stimulate some discussion about the topic rather than for anything formal or evidence-based. So I went to typical search engines like PubMed, Medline, and I've also gone through Google and Google Scholar because some of the guidelines on sickle cell disease don't naturally go into medical peer-reviewed journals, but they are standalone publications. And I tried to look at the literature for the past 15 years or so that we don't include any guidelines that are older than that date, typically using typical search terms revolved around sickle cell disease and its manifestation, and to capture anything on the wide spectrum of consensus statements, expert panels, or guidelines in specific as they are labeled by the authors. Definitely, the focus would be mainly on regional or international guidelines or specific local guidelines if they have any international audience in terms of their development. I'm sure there are many guidelines that weren't included here, and I apologize if that was missed, but some of them were purposely left from this analysis because they represent very hospital-based or local guidance for the purposes of quality assurance only rather than guidelines that are intended for wider medical community use. What I'll be doing is featuring those guidelines because part of this comparative analysis is to describe the guidelines and how they were developed, their scope, any metrics related to their development. And then I will go a little bit into some of the subtopics within the guidelines to see how different guidelines feature certain indications for use of intervention, for example. So I've gone region by region for that purpose, starting initially with North America. This is the consensus statement on the care of patients with sickle cell disease in Canada, published in 2015 by the Canadian Hemoglobinopathy Association, CanHEM. It also had some sort of endorsement and forward by the Sickle Cell Disease Association of Canada. It was the first ever national guideline document to be released on sickle cell disease in specific. You'll see that I will feature this table for each of the guideline, and this is basically to try to look at them in a formal or formalized or a standard way. So I will be looking into the methodology of the development of the guidelines, the number of pages, just to give a sense of its size and depth. And if there were any disclosures, because usually that's one of the criteria looked at when looking into analyzing or assessing guidelines, whether disclosures about the authors or about the development of the guidelines were also mentioned. So specifically for the Canadian guideline from 2015, there wasn't a specific chapter or anything on the methodology. It looked like it was written by expert group of authors, forming an editors group, lead authors, contributors, and then some assigned as reviewers. It didn't go into any levels of assessment, any grading of the evidence, and it mainly was a description of the literature plus some sort of consensus recommendation from the author group and the contributors themselves. It's very wide in terms of coverage. It starts with 2 dedicated chapters on transfusion and hydroxyurea, and then going into prevention and management of specific complications, typical complications that are seen in sickle cell disease, and then a dedicated 3rd section on comprehensive care, looking at aspects of perioperative management, pregnancy, then going into newborn screening, immunization, transition of care. It also has a dedicated chapter on comprehensive care centers, and how these can be established and creation of a Canadian network per se. The typical layout, if you go into these chapters or these guidelines, it starts with some principles of care that are agreed on by the authors, and then follows with recommendations, and then the background, the research, the literature evidence that feeds into those recommendations and justifies them, and then a dedicated list of references for each chapter. Then moving south to the United States, so we have the NIH, or National Heart Lung Blood Institute, NHLBI expert panel report that was released in 2014. It's an update of the prior report from 2002, and I also put this information to see how long it's taking for specific entities to update the guidelines. It has wide endorsement by almost most relevant societies in the States, including ASH at the time. And it has a very rigorous methodology for development. It's formed of an expert panel, the authors group, including chairs, members from NIH and from outside, from dedicated centers of excellence in the US. And there was also a methodologist assigned specifically for the development of these guides or panel recommendations. And it also relied on independent external reviewers. It starts off with looking at key questions developed using the PICO standard, then looking into the literature and preparation of evidence reports. And then these were subjected to grade quality assessment for evidence and strength of recommendation, and the AMSTAR standard for the quality of systematic reviews. And when the evidence wasn't available in the literature, there was adaptation of published consensus statements or expert panel consensus to agree on certain elements that doesn't necessarily have enough evidence on it in the literature to follow any grade criteria per se. Coverage, it starts off with health maintenance aspects. Again, everything related to prevention, screening, immunization, clinical preventive services per se, and how they need to be structured and made available. And then going into acute complications, chronic complications, followed by dedicated chapters on hydroxyurea and transfusion use in specific. And there is a forward-looking statements at the end, looking into aspects of unmet need, gaps, and looking at research data systems, collaborations per se, and interactions with the community, so that it's more or less a holistic approach to care of patients with sickle cell disease. The chapters themselves are very well structured in terms of going into the background. Again, repetition of the methodology of development of recommendation in case there were anything specific for a specific aspect of management beyond the general methodology. And then there are key questions that are laid out by the authors, summary of evidence, and then the recommendation, as I mentioned, the graded recommendation in terms of indication, quality of evidence, and strength of recommendation, and consensus statements when the evidence is not enough for official recommendations. This panel recommendation was also released and repurposed or published in different ways. There was a summary article publications in JAMA in the same year, and there was also a summary for primary care physicians that I found very useful and interesting, published also in the American Family Physician Journal in 2015. There were a couple of initiatives that came out after the guidelines were made available by various groups, and these were mainly to address specific unmet needs that were still persistent in terms of the guideline application, familiarity of physicians with the guidelines and their adoption, specifically for matters of hydroxyurea use. Usually they were the main aspects of management that adoption of guidelines wasn't as high as one would expect, and the management of pain, acute or chronic pain. So this initiative, the Sickle Cell Disease Implementation Consortium, which is again an NIH-LBI funded cooperative research program that is conducted over several years. This is the layout of it that was published in 2018 by Di Martino and colleagues, where the first phase of the development looks into conducting needs assessment and implementation studies to be able to understand the perspective of stakeholders that would be involved in application of guidelines and the setup of management of care, to look into any gaps that require addressing, and also to establish a sickle cell disease registry, which was deemed the best way to be able to follow up if guidelines are being implemented and applied as they should be. This is again another project that was also dedicated around the guidelines, Project ECHO or Tele-ECHO as it was called specifically. And this was more of a mechanism to enable physicians, specifically primary care physicians, to increase their understanding and awareness of the guidelines through teleconsultation with experts, so that they can go over aspects of the guideline that require further elaboration, and ensure that the primary care physicians are more comfortable with the guidelines, they understand them, so that they can apply them in their setting, whether it's a private care or community setting. And that was obviously with the aim of increasing the adoption and application of the NHLBI guidelines in specific. ASH has its own guidelines, set of clinical practice guidelines that were published in the last few years. Again, the rationale, if you look at it, how at least the ASH website lays it out, it was also stemming from the need for primary physicians and other allied healthcare workers in emergency departments, nursing staff, their need to be more comfortable with the management guidelines in sickle cell disease, because some surveys showed that there is some sort of lack of understanding sometimes, or lack of comfort with the guidelines that are available. And the ASH also had in its vision to make these guidelines also friendly for patients and caregivers, to increase their engagement with the healthcare providers by being able to follow up on the standards of care that are applicable to their disease. It was, again, a process that started in 2016, a collection of panels into 5 panels. Almost 70 physicians were involved in the development of guidelines and appointed. A lot of consideration went through looking into conflicts of interest to make sure that these are addressed before the development. And then there were patient representatives that were involved also in the guideline development, at least 1 patient representative per panel. Following a typical process of systematic review of the literature, development of recommendations, but more importantly, obtaining stakeholder input on these before they are published in Blood Advances, one of the journals of ASH, recent journals of ASH. And this is again a description of the process where the evidence was looked at in the eye of questions related to patient care. For each aspect, for each panel, there were 10 questions that were agreed on that are most important, again in the PIPO format, and then the evidence was looked at based on these questions, and then the recommendations were made and input was sought from the various stakeholders. Various strict criteria were involved. The Mayo Evidence-Based Research Program was involved in the looking at things systematically, and the GRADE approach was used to assess the certainty of evidence and in the formulation of the guidelines. What I found interesting is in each of these guides, there is a section that's repeated in all of the guides that gives some sort of hint on how guides or recommendation can be interpreted by patients, by clinicians, and also by policymakers and researchers. When the guideline says strong recommendation, what does that mean? When it says conditional recommendation, what does that mean? And these are the 5 available guidelines so far on acute and chronic pain, cardiopulmonary and kidney disease, prevention of and management of cerebrovascular disease, stem cell transplant, and transfusion support. And these are all available and published in the journal Blood Advances. There are also some interesting companion publications about how to use the guidelines, the challenges that were met during its development, that if you're interested, you'll be able to read them through these references. What's also unique to the ASH guidelines is that it comes with a lot of resources. If you go to the ASH website, it has a snapshot documents that give you a very quick summary of the guidelines, pocket guides for clinicians, teaching slide decks, and also applications for the guideline and for the pocket guide itself, and podcasts. So whatever your preference in terms of format, you'll find some sort of resource that gives you the details of the recommendation in the format that's most suitable to you. And this is all coming in line with some studies that were conducted by groups that were involved in the ASH guideline development, looking at the needs of patients and how they view technology as an enabler for them to be able to have access to simplified versions of the guidelines. So ASH did a good job, I must admit, in addressing such need that is clearly identified by patients themselves. Of course, there are several disease-specific guidelines from different societies in the US. So the American Heart Association, American Stroke Association also released guidelines for the management of stroke, including patients with sickle cell disease in 2014. The American Thoracic Society also has guidelines for the management of pulmonary hypertension and sickle cell disease. And the American College of Obstetrics and Gynecology has a bit of an older guide on pregnancy and management of pregnancy and hemoglobinopathies in general. Moving on in Europe, there are few guides that are available from Europe. There is this INERCA, I would say, short publication in the American Journal of Hematology back in 2011 by a group of authors publishing these guides on behalf of the European Network of Rare and Congenital Anemias. The methodology was again based on the regional expertise of the author group. There wasn't a level of evidence assessment as part of the recommendations or the statements that were in it, but it is as small as it is actually a full coverage and goes over various aspects of the disease. There is also an international recommendation, but it's primarily coming up from experts in Europe on behalf of the EBMT, specific to use of transplantation in both thalassemia and sickle cell disease. Again, it went through a rigorous methodology of collection of evidence and going through great approach for evidence assessment. So it was conducted by an author group, and consensus meetings were again needed to establish consensus over various aspects of it. Again, financial disclosures were available. There was some pharma unrestricted financial support for the development of this consensus, but no involvement in the actual consensus process itself. There are also other country-specific guidelines from few countries in Europe, at least the ones that I was able to find. This Italian Society of Hematology guides from back in 2008 covering thalassemia and sickle cell and other congenital anemias specific to iron overload. Same guideline specific to iron overload from Germany. And there is a pan-European consensus conference statement or recommendation specific to newborn screening from the EuroBloodNet group. The UK also has its robust share of guidelines that have some international presence and adoption by different countries. There is the famous Sickle Cell Society guidelines split into adults and pediatrics and children. The adult new guidelines were published in 2018 by the Sickle Cell Society. It is an expert authorship in terms of the way it was developed, literature reviews, expert opinion, also going in parallel with regular meetings and sharing the recommendation with the sounding boards. And it gives you sets of standards and recommendation. But what's nice and interesting in this guide is also it includes patient quotes and information from patients through patient surveys, which I found very interesting. It's very elaborate in terms of coverage. It goes through general principles, management of acute and chronic complications, and then additional management aspects related to reproductive health, surgery, and looking at specific therapies and transplant and emerging therapies. It has interesting forwards in it, the guideline from various members involved in the management of disease, and even statements from key political figures in the country. It usually starts with a quote from the patient, going into an introduction, standards of care, and then the background for the evidence from the literature review, and then the recommendations. Similar format and style for the children, for the childhood piece, which is also published by the Sickle Cell Society with Public Health England. This was an update from the 2010 recommendation in children that was released by the NHS screening programs at the time. Again, a full coverage scope for ongoing issues, chronic complications, acute complications, surgery and perioperative care, and specific treatments, including hydroxyurea, transfusions, and transplant. The British Society of Hematology has a set of disease-specific guidelines for sickle cell disease. These are published either by the British Society of Hematology or by a specific committee, the British Committee for Standards in Hematology. They go into more or less a similar methodology where there is, and that methodology itself is available at the British Society of Hematology website, where there's an expert group selected by the society conducting the literature search. Then this goes through multiple layers of review, including presenting the evidence to British Society of Hematology members. Around 50 UK hematologists as well are selectively chosen to review the recommendations by the author group, and the grade criteria are used for recommendations to assess the level of evidence and the strength of the recommendations. And most of these have a statement at the end indicating that they will be reviewed in 5 years. So they are split for In 2015, there was one about the management of acute chest syndrome. 2016, principles of transfusion care, split into two parts, principles and laboratory aspects, and then indication for transfusion. And then a specific guide on the use of hydroxycarbamide released in 2018. And more recently, just this year, there was two guides, one on iron overload monitoring and management for hemoglobinopathies in general, including thalassemia and sickle cell disease. And within the guide, there are specific indications for sickle cell disease are relevant, and a guide on the management of sickle cell disease in pregnancy. There are other UK guidelines. There are also recent guidelines by the Association of Anesthetists on perioperative management, and older NICE guidelines on the management of pain. And the Royal College of Obstetrics and Gynecology used to release the guidelines for management of sickle cell disease and pregnancy, but this guideline is now what was taken over by the British Society of Hematology that I just referred to. In Africa, I found country-specific guidelines. They're usually collectively short in scope, looking at specific aspects developed by an author group, either released by, for example, this national guideline from Kenya, released by the Ministry of Health, members of the ministry itself, and expert group, and sometimes collaborating with international advisors. There was, I must admit, some industry contribution. So industry personnel were contributing to the guidelines, but that might be the case in terms of the provision of care, and there is some strong industry involvement in having proper access to therapies in the continent and specific countries, and that's why I would assume their involvement in the guidelines was there. The same again, guidelines in 2014 from Nigeria, looking into various, very comprehensive but concise in the same way, and developed by various members from the Federal Ministry of Health and external advisors as well. There is also a published guideline from South Africa, specifically by a local expert group back in 2014. And finally, in Australia, the main guideline I was able to find was one looking at iron overload, not necessarily specific to sickle cell disease. This combined thalassemia, sickle cell disease, and other congenital anemias. Again, formulated by a local expert group, a panel with a review of recommendation, but no evidence level assessment per se. And it combined, as I said, recommendation for thalassemia and sickle cell disease. So in this last part of the presentation, I'd like to give you a hint of how things compare. We've done this exercise previously. That's why we've done this again with colleagues from TIFF, Dr. Andrukla and Dr. Michael, and also Professor Porter was with us on that. We've done this exercise in thalassemia, looking at beta thalassemia major, TDT patients in specific. So we wanted to do something similar here for sickle cell disease, but I must admit that it's a much harder task because of the long list of complications, acute and chronic complications with very specific aspects of management, which makes it hard a little bit to put things head to head to compare how guidelines describe things. But I tried to do that for a few elements of intervention. And I just wanted to feature this let's say, agree methodology that is adopted sometimes to assess for the quality of guidelines in terms of scope, stakeholder involvement, rigor of development, clarity, applicability, and independence or conflicts. I found an interesting publication done by a group from Saudi looking at actually the obstetrics and gynecology related guidelines for sickle cell disease, where they've done this exercise to look at the RCOG, the NICE, the ACOG, and the NHLBI guidelines to assess them in terms of how they adhere to these criteria or domains of the AGREE guidelines. And it's something that I think is interesting to be done for the majority of other indications in sickle cell and thalassemia for that purpose. So looking at comparing the guidelines, I looked into indications for hydroxyurea, for transfusion, and for iron chelation, because they should be, you would expect that they should be uniform across the board. When it comes to hydroxyurea, there are those aspects that everyone agrees on when you look at the use in adults for recurrent pain crisis or for pain interfering with quality of life or recurrent or severe ACS. there was some sort of agreement. When the cells are empty, it means that these were not mentioned specifically in the guidelines. Probably they were out of scope for what the guidelines were designed for. But then when you look further into specific aspects of management when it comes to stroke prevention, for example, there was also, again, agreement, but definitely you see the influence by the evidence that is available at the time, where you see in the recent ASH and the British Society of Hematology guidelines, there is that agreement in terms of the use of hydroxyurea in children who has been on transfusion for at least a year, who wish to transition from transfusion. And this is obviously stimulated by the Twitch study and data available at the time. While if you look at older studies, older guidelines, you would not see such a recommendation. When it comes to transfusion, it's more or less the same picture. The indications for transfusions were more or less the same, again, stimulated by the scope and year of publication of the guidelines. When it comes to acute use of transfusion for aplastic crisis, clinic sequestration, hepatic sequestration, or symptomatic anemia, this was unanimously indicated across guidelines. When it comes to recurrent pain crisis and recurrent ACS, there was some sort of mention of the use of transfusion as a second line if hydroxyurea or other therapies are not working. And then when it comes to primary stroke prevention, there was the clear indication for primary and secondary stroke prevention, although with some variation, whether it's indicated for children and adults or for children only, depending on which evidence or which clinical trials at the time. When we look at indications for iron chelation therapy, again, some variability here, but nothing major. Most of the guidelines obviously recommend regular monitoring for iron overload and patients receiving chronic transfusions. Definitely serial serum ferritin follow-up is indicated, usually at a interval of 1 to 3 months, but the use of LIC or by MRI or cardiac T2 star was conditional in most of the guidelines. Maybe in ASH there is a recommendation that is done every 1 to 2 years, but for cardiac T2 star, for example, to be only done if LIC is high, and the same is the recommendation is done by the British Society of Hematology. While, for example, the Canadian guidelines recommend regular use of LIC and cardiac T2 star when patients on chelation, while in some other, like the Sickle Cell Society, the LIC is only indicated, for example, if serum ferritin is high. In terms of indication for a transfusion, usually that's very lightly described. It just requires documentation of iron overload. And if there are certain metrics or indicators, these are usually the load of transfusion, some quoting 10 to 20 transfusions, some quoting a year of transfusion worth of transfusion. And when it comes to iron threshold, usually it's a serum ferritin of more than 1,000, while others recommend LIC thresholds for indicating iron chelation. In terms of choice of therapy, as you would expect, the British Society of Hematology and the Australian guideline, because they were specific to iron overload, there was details of indications, but for the majority of guidelines, there wasn't any specific chelator that is recommended. Usually the use of DFO or DFX, and sometimes mentioning the ferriprone, although noting that it's not indicated for sickle cell disease in the country or in the region, at least for that matter. So in summary, the guidelines are there, and they do have variation in terms of how they're presented, the methodology they're undertaking to come up with the recommendation, the scope and breadth of them. But the majority of guidelines are comprehensive enough. So if you get your hands on any of those, you will get proper management indications and guidelines for sickle cell disease. But the variation is the most obvious and clear one is the year of publication. So it's very much related to the evidence that is available at the time. The scope and the depth of the guideline itself. So some guidelines just wanted to touch on specific aspect and not go into the comprehensive care of patients. The format and specification of the recommendation, whether the grade, for example, levels of recommendations are there, you would see that there would be variation in recommendation if that is applied. And then again, some guidelines were purely scientific, looking into available literature, while others, for example, like the ASH and the Sickle Cell Society looked into patient preferences, patient centricity aspects beyond the scientific evidence to inform the recommendation. I hope this was informative to you, and I'm happy to take any questions for further elaboration. Thank you.
Thank you, Dr. Msalem, for this very, very interesting and educational session. On behalf of Professor Odami and myself, I'd like to thank all presenters for their stellar and multifaceted presentations, and that we thought we'll have just a wrap-up session with few recommendations that are coming out from the sickle cell disease session. As you've heard, sickle cell disease is a multi-system disease with a complex pathophysiology highlighting the need for multi-targeted therapies. As healthcare providers, we need to regularly listen to, and that's very important, learn from, and know our patients very well and their psychosocial status, and keep educating them and their caregivers. As healthcare providers, sickle cell disease and non-sickle cell disease, and particularly ED physicians caring for patients, need to be regularly educated about sickle cell disease and all related updates. Very important to screen for sickle cell disease early in the newborn period and follow that immediately with preventive therapy, including vaccination, penicillin prophylaxis, hydroxyurea, parental education, and screening for complications and early treatment. And if we want to do optimal sickle cell disease therapy, it has to be done. It has to be patient-centered, done only in sickle cell disease expert centers by a dedicated multidisciplinary team and with an individualized approach. It's very useful, and so that we can accommodate the patient's comfort, to network with community centers. This will facilitate care, provided these community centers are regularly educated about sickle cell disease care. Transition is associated with high morbidity and mortality, and is a highly vulnerable period that deserves a dedicated multidisciplinary sickle cell disease team and center. We need to anticipate and promptly treat complications, particularly in the context of VOC, because these could result in unpredicted sudden death and significant morbidity. And different from thalassemia, transfusions are recommended in sickle cell disease in selected cases only, and when they're indicated, you need to give them safely and do proper antigen matching to avoid complications as alloimmunization and delayed hemolytic transfusion reaction. With the optimistic influx of so many promising novel therapies, people living with sickle cell disease can benefit from combination therapies like cancer patients. But it's very important to realize that hydroxyurea, which has been for years and years and withstood the challenges of time and proven its efficacy, needs to stay on board, except if there are any contraindications to its use or there's no response at maximum tolerated doses. As you've heard in the last session, several guidelines, standards for clinical management of sickle cell disease from various societies and countries, the most recent being ASH guidelines, have been laid down, but there are still so many unmet needs, variabilities, gaps, and challenges. Healthcare providers treating people living with sickle cell disease need to be aware of these guidelines, but you need to remember these are just guidelines, and their care must be based on patient situations and patient preferences. Incidentally, most of these guidelines had patients and caregivers as part of the team. And finally, the future is optimistic for people with sickle cell disease. Thank you, and I leave it to Professor Odami.
So we are going to have the questions and answers session at the moment. So I leave it to be moderated by the European Sickle Cell Society.
Hi, everybody. That would be me. My name is Janika Leah. I'm an award-winning author and publishing house, JLG Publishing, and also a part of the ESCF Management Committee. That's the European Sickle Cell Federation. I live with sickle cell anemia, HBSS, and I'm also from Birmingham in the UK. So before going to the question, just to give a brief kind of introduction to myself and also the European Sickle Cell Federation in Birmingham, which has the second highest prevalence of sickle cell patients of all the cities in the UK. I've been quite a trailblazer in creating resources that educate and spread awareness about sickle cell disease since I published the first children's book series about sickle cell, which was back in 2016, which is entitled My Friend Jen. That actual children's book series has now been used by various healthcare professionals, as well as families and young people, to help them understand what sickle cell is and the fundamentals of how people living with it can stay well, as well as for children living with sickle cell to build their confidence in understanding what they are living with and being able to speak about their experiences to reduce the societal stigmas and lack of awareness around the condition. So in 2019, we began the idea and proposal of a patient-led umbrella organisation for Europe. And in 2020, these ideas came to fruition, and the European Sickle Cell Federation was registered as an organisation. Of course, we then had the unprecedented beginning of the COVID-19 pandemic, which meant it kind of disrupted our planned events. So a virtual launch to the public on World Sickle Cell Day in 2020 was how we presented ourselves, followed by our first official webinar a few days after that in 2020. We actually celebrated our first year existence as an umbrella organization in June of this year, and we held our inaugural European Sickle Cell Disease Summit for patients and patient advocates in September. So European Sickle Cell Federation, ESCF, we continue to be united as the umbrella network of sickle cell patient organizations in Europe. We continue to engage with our stakeholders and members to address any improvements or anything that may be of concern to any of them. We also continue to be consistent in our work and to be aligned in our focus and vision as a one European umbrella network for sickle cell disease patient organizations that has one united voice for sickle cell. So that's just an overview there of the federation, what we are and what we're about. I will go to the Q&A now. We have a question which is from Sotrula Christou. Thank you, an excellent presentation, which I will agree with. Today's been very informative. It's definitely been beneficial for those that have joined. They'd like to ask about the prenation of liver disease in sickle cell disease, and what about the D-dimers? Is this an indication of thrombosis for sickle cell patients? Not sure who would be best to answer that question.
Lucia, will you want to take that?
So I'm starting. Otherwise, I don't know if anyone want to just jump in. And I'm taking care of adult patients with sickle cell disease, and the D-dimers is always increasing patient with sickle cell in adults, and is you can consider an indirect marker of inflammatory vasculopathy. So the changes in D-dimer is definitely more related to this chronic inflammation and vascular activation than per se as an expression of on the other side. Of course, any changes is that are going from historical data of each patient during acute events should also be explored, since sickle cell disease is a thrombotic disorders. And so it's difficult to connect these only with liver disease and prevent in sickle cell is very complex, since the definition of sickle cell liver disease is a melting pot of different conditions, going from acute events to cholangitis to ischemic damage of the liver. So maybe someone else wants to comment.
Miguel, you wanted to add something? You're muted, I think.
think mute.
Sorry, I have a comment and a plea for help with a question from my dear colleagues. I agree with what Lucia said, that the dimers are elevated in sickle cell. They can be elevated, particularly in the context of acute chest. But what we have noted in children and young adults, we've had 30 so far who acquired COVID. And 3 or 4 of them, if we are in the process of preparing this, developed delayed thrombosis, splenic infarct. One had a saphenous vein thrombosis recurring where he had a previous thrombosis years and years before, and one had bilateral fulminant strokes. All of these were associated with high D dimers going into the thrombosis. Now, having known that, has anybody seen these as delayed complication of COVID in sickle cell patient, delayed thrombosis associated with high D dimers? And again, I agree, the confusion here is that in sickle cell, we have baseline elevated D dimers. They can be elevated with VOC and acute chest. So I was wondering if anybody else had experienced this.
Miguel, I can comment if you like.
Okay.
So in the UK, we've had about 900 patients with positive COVID. Not all of them have been very sick, but we've certainly seen a lot who have developed thrombotic complications, usually pulmonary embolism associated with pneumonitis and inflammation. So I think your experience is probably typical of a more severe COVID illness in sickle patients.
Well, anyway, I don't want to belabor, but these had not so severe COVID, but they developed the thrombosis late. So now I'm being much more liberal with the low molecular weight heparin and keeping it on in these patients.
Miguel?
Yes.
Any of these, you've mentioned one patient had predisposition to thrombophilia. Have you screened the other patients for previous thrombophilia? Were they at high risk?
None of them had thrombophilia.
Okay.
One patient had a previous thrombosis about 8-9 years back, where he had a central line, and this thrombosis in the femoral vein, and this thrombosis recurred now after he acquired COVID.
Okay.
Yeah, but his thrombophilia workup at that point was negative.
There's no doubt that the SARS-CoV-2 virus is very thrombogenic, very, very thrombogenic. And so thrombosis as a complication, it doesn't matter what disease predisposition, doesn't matter what age, there's increased incidence of thrombosis, which is what virtually all countries have observed.
Don't know if there's no more questions in the Q&A. I wanted to ask a question regarding blood transfusions or blood exchanges as a form of treatment. I know it's been mentioned that it could be continuously used after having a stroke. But in the cases of patients that haven't had a stroke, but are now being recommended to kind of use blood transfusion or exchange quite often on a 4 to 6 weekly basis to treat sickle cell, what are the, or are there any evidence of this to improve the kind of longevity of sickle cell patients? Is it the lifespan or anything else?
So if I get your question, you're asking whether chronic blood transfusion could be established as a disease-modifying therapy to improve quality of life and longevity.
Yes. Yeah.
Right. Paul, you want to take that?
It's a very good question, Jessica, and I think there were some slightly conflicting statements, I think, from our experts in the session today. And I think that does reflect a degree of uncertainty about the role of long-term transfusion for some of these other indications. We all agree that for stroke prevention, it has a role, but it certainly, I think the practice and the experience is quite different across different healthcare systems. And as you rightly say, in the UK, there's quite an emphasis now on using this as a disease-modifying treatment for other to prevent acute problems where hydroxyurea hasn't worked or where the patient doesn't want to take it, and to prevent long-term complications. So, for instance, in patients with pulmonary hypertension, some of those who've had renal transplant, for instance, and we certainly use this a lot in adults who have had recurrent pain episodes and where hydroxyurea hasn't provided sufficient control. And in our experience, it can be very effective, but there are a lot of problems, and it's not an easy program.
Okay, thank you. I think that's all for the questions, so we can wrap it.
So with that, I think since there are no questions, I think we've exceeded our time actually. On behalf of my co-chair, Adlet, I want to thank all of you for this very, very exciting presentations that really are elucidating our understanding of sickle cell disease. The message I would say is that, and I think Khaled emphasized that, there is enough recommendations available to guide every clinician as to how to manage some of the acute and chronic complications of the disease. The challenge we have is how to make what we know works actually happen for the patient. And I think a recent report from the UK suggesting that just having guidelines and having them available doesn't always translate to real care for the patients. And all of us have to be advocates to make sure that what we know works actually happens to the patient when they need it at the right time to improve their quality of life and to prevent catastrophes. So thank you very much. Sickle cell disease is the care of sickle cell disease is improving, but there's a lot more work to do to achieve the target that we're looking for. And with that, I think we'll bring the session to a close. And I wish you all successful rest of the weekend and rest of the week. Thank you.
Thank you.
Thank you.
Okay.